Good to see many of you again. Been off in the residency world. So for those of you who were here last year, this may be a bit of a review. By 5, you're a cardiologist and an otolaryngologist. By 8 years old, you've got your PhD in education, and then mental health rears its ugly head. So I'd like to just kind of give you an overview of what we know about mental health and try to deliver it from a perspective of somebody who's new to the field. So if I use jargon, say stop and make me explain it, okay? Because it's a problem with talking to doctors. They can forget what it's like not to be familiar with all the assumptions we have. So who am I? I'm Joel Johnson. I'm actually a psychiatry resident, like the guy in the Scrubs TV show that runs around and takes care of things in the hospital. I was given a year to work with Tony in the cable lab, and I've been keenly interested in 22q since and the community. So what I'm going to talk about is not just the disorders, what to look for, but also about temperament. Often that's overlooked, but that is an important aspect of mental health in 22q. Temperament means the part of the personality you have that you're born with, that's innate. That's the best way I can describe it. I'll also talk about, all through it, medications, mental health professionals, and mental health research. They'll just be intertwined in the whole thing. So why are kids with 22q so prone to mental illness? And I think one of the core reasons is just brain development. You know, the common deleted region carries genes that tell neurons or help neurons know where to crawl when someone's just gestating. There are also key genes that regulate how neurons talk to each other. So with those key genes dysregulated, it's no wonder that kids with 22q develop mental illnesses. But I've got really good news, and it's from Dr. Bassett's talk last year. And she says people don't talk about this often enough. But in the longitudinal studies that have tracked people over 20 years, 43% of people with 22q will not develop a mental illness. And it's easy to forget that, but there's a lot of resiliency in the population. Secondly, if you just go to the general population and ignore the genetic hit, there are vulnerabilities. One is the sick role. And the sick role is actually a clinical term, and it's been well recognized for 40 years that being the sick one in your family causes lots of problems for everybody in the family. Okay, not just the person who's in the sick role. And that sick role can persist throughout your life, even if you stop taking on it in the family structure. Traumatic surgeries really early on are known to lead toward proclivity to anxiety and post-traumatic stress disorder. The direct effect of illnesses, hypocalcemia, seizures, sleep apnea, these can have symptoms that look just like mental illness. And then finally, growing up with the deletion. And I think someone already asked the question, what is it like to be a kid where you're aware that you're different from other kids? Between, for example, at 6 years old, that's the beginning of stage where you want to know that you're just like everybody else, and it's really important to know that. And I think the responses you actually got were kind of like a nice summary of what the field knows about how to deal with that. And then physical development and mental age mismatch. Dare I mention puberty? Yeah, those hormones, they start going, okay? And what happens then? I think I'll just leave it at that. So temperament. The top line there, that's the best definition that anyone can come up with. But temperament in children with 22q, these are the 4 things that have been distinguished from the general population in children with 22q. That's pretty reliable. You can expect less focus in regular daily activities. Well, that goes right along the line of the attentional issues that Dr. Simon will probably talk about. Less cheerful. I'm not sure that varies a lot from my experience with kids with 22q. Definitely less flexible, and maybe not less social. I should say differently social, and that's an area of hot debate right now. interestingly, as those who work with children with general neurodevelopmental disorders, these are not necessarily unique just to 22q. So if you have a provider who's just aware of neurodevelopmental disorders in general, they'll probably have some pretty good interventions for all of these temperamental issues. Okay, so I said 43% of kids with 22q will grow up and never meet diagnostic criteria for a mental health disorder, and I will explain that jargon. But that means that most kids will be affected with something. Okay, and I think I already spoke about neurodevelopmental stuff in the previous slide. So before I go on to the mental disorders, I have to explain what a mental disorder is. As expert cardiologists and ENTs, you may be thinking of the medical model of disease when you first start hearing about mental health disorders, and it can get really confusing, okay? And it's going to be very difficult to adjust to. So what are they? A disorder is not a disease. A disorder is a term that was created in 1980 to describe clusters of psychological symptoms that were significant. They didn't want to use syndrome, which is synonymous with. It's different from a disease, and disease technically means that there is like an identifiable something off, atypical, that causes symptoms, okay? So a disorder means just a cluster of symptoms together. These symptoms in psychiatry are behaviors, mood, affect or expression of mood, cognitive abilities. So the problem, and I just illustrate this like by analogy, the problem is if you're kind of clustering disorders just based on their symptoms, it's kind of like ornithology. If you live in North America and you classified everything with a bill and webbed feet as a duck, and then you go down under, you realize that not everything classified by its outward appearance is what you think it is. And this has been the problem in 22q treatment of mental disorders, okay? There's only one mental disorder that in 22q that we know is like the mental disorder in the general population. Does anybody have a guess of what that is? Schizophrenia, that's it. It's the only one that's been researched over decades and has been shown to have the same prognosis, the same treatment, and the same onset or symptoms. So if it seems fuzzy, if there's lots of debate about things like autism, OCD, and all that stuff, it's kind of because of this. And I'm 32, so I only mention that because I'm older than our current classification, all right? 1980, that big green book there, that's when the classification started. So it's a really young field, and it's confusing. So the point is if you're going to buy into a label, don't get caught up in semantics. Make sure whatever the label is in the mental disorder communicates the core problem. Does the label, when you look at it yourself going to NIMH or going to NAMI, does it actually describe the group of symptoms? Okay. Will it suggest the right treatment? And does it predict the future? And again, we only know of one that it does predict the future, and that's schizophrenia. So with that big warning, this is what I've reviewed in the literature that are common. Oh, thank you. This is what I reviewed in the literature that are common mental disorders in childhood in 22q. Attention deficit hyperactivity disorder, which is usually inattention disorder in children with 22q. Anxiety disorders are very prevalent, up to 60%. However, this seems to drop off by adulthood, and only about 15% of adults are afflicted with anxiety disorders or meet criteria for anxiety disorders. Mood disorders are a hot topic and very controversial because the field doesn't know what the difference between bipolar disorder and major depression is. So if you're confused by it, it's because we are. And then autism spectrum disorders, again, very controversial. In fact, most of the papers in the last year have been about arguing over whether or not the social differences in kids with 22q is actually autism or not. And that is just not known. So I have a whole slide on that. And then finally, I put the schizophrenia prodrome because this talk was about the early signs of schizophrenia last year, and I wasn't talking about schizophrenia, but 25% of kids who have 22q will go on to develop schizophrenia or schizoaffective disorder. And you can kind of catch the prodrome or the early syndrome of schizophrenia, and I'll talk about prodrome in a little bit, it's another jargon, in adolescence for about half the people who go on to develop schizophrenia. So ADHD, what is it? I told you the prevalence, the core symptoms, what it describes is impulsivity, hyperactivity, and inattention. But in 22q, it really kind of is inattention. I haven't seen a whole lot of, in my limited clinical experience, of impulsivity, well, maybe some not thinking, but, or hyperactivity. And then you may be surprised as a parent, wait, my kid didn't have 22q at 5, my kid didn't have ADHD at 5, then they went to kindergarten and suddenly they have ADHD? It's because of the way it's described. You have to have two settings where this inattention is problematic. And so it's just an artifact of the system. So you enter school, the inattention gets you in trouble, and suddenly you've got this label. What does this label predict in the general population? Again, we don't know what it predicts in 22q, but in the general population, this has been very well researched, and these are all the things that it predicts. I'm not going to talk about all of these things. You can download this presentation and look at why people are so hot to treat it, okay? Even though the treatment is controversial. But in the general population, we do know that 30 to 40% of people who meet criteria for ADHD will have symptoms or meet criteria for ADHD as adults. And every time I see this, I go, oh my gosh, is that right? And then I go back and review the literature, and it's true. Okay, oftentimes I've seen as low as 9% in studies and as high as 68%. But in general, most reviews stick with 30 to 40%. So this may be called bipolar later by some clinicians. ADHD treatment is multimodal. Medications are an important part of treatment. And this is where it's tricky with 22q because direct stimulant medications may confer a risk for hearing voices or being scared. Okay. Non-stimulant medications, there are some, have an unknown risk for that. But we do know that kids with 22q are commonly treated with stimulant medications and they do okay. So this is just a research question now, and it's something to talk to your doctor about.
What age do you tend to see this emerge and start to treat?
Well, it's sort of like when you get into school. As soon as you get into a structured setting, that's when people recognize it, although it's apparent from really early on, the inattention problems. And I think that Ingrid talked a little bit about the executive issues that could be apparent early on, so that gets confused with the whole ADHD. ADHD is definitely a disorder with a lot of different causes, and it's not very specific. Just think of it as distractible inattention. Well, that's a good question too, because one of the environmental changes that happens in school is that there's a lot of distractors, and all the things that you as a family have done to compensate for that inattention go away. So the mainstay of therapeutic treatment, environmental therapeutic treatment, is just kind of remove the distractors. Okay, so oppositional defiant disorder, this is kind of like a dark diagnosis, and I mention it because it's really important. It's kind of like a family diagnosis. Oppositional defiant disorder occurs in ADHD. Oppositional defiant disorder is generally a diagnosis of temper outbursts, active refusal, and being annoying. And it's... there is a threshold for it. There's times when it's normal. It's adaptive to be temperamental, annoying when you're in your terrible twos as you're learning to separate from mommy. And it's also important in adolescence when you're trying to prepare everyone to kick you out of the house when you're 18. So this is a problem, though, in the middle school years. And what really makes kids with ADHD in general vulnerable with it, and probably kids with 22q, is it's like a disorder of over-frustration a lot of the times. If you have ADHD and you're missing social cues all the time and everybody's mad at you for a reason that you can't even tell why, it kind of makes you angry. And how are you going to express that? So that's just one example of how it can develop. Not all ODD is the same, and I'm just kind of giving an example of how it can develop. So in the general population, it most often goes just away. Okay, the environment changes, people grow out of it, except for the aggressive subtype, which can lead to substance use problems and conduct problems. And this is important in 22q because about 20% of kids with 22q will grow up and develop either conduct issues or have a substance use problem. So if ODD crops up, it's important to look at it in the face and treat it. For younger kids, family therapy is the mainstay treatment. There's no real medication for ODD. There's no, as some of my patients like, can't you just give them a pill to make them behave? There's no pill to make them behave. As the child gets older then individual therapy may be your only option, particularly if they become very defiant in an adolescent. It may be a bit too late for family therapy. And that just affords someone practice with a neutral adult. Now, these aren't necessarily evidence-based therapies, but it's sort of the best the field has to offer. Anxiety disorders, specific phobia basically means you're afraid of one thing too much, and that happens quite a bit in 22q. But that can be pretty well compensated for, but usually families develop a way to compensate for that. But obsessive compulsive disorder and generalized anxiety disorder are very problematic in kids with 22q, affect quite a few of them. And interestingly enough, like I said earlier, they can remit spontaneously because only about 15 to 20% will have an anxiety disorder growing up. There's also, I've heard this story a lot of times. For some reason, it seems to take a long time for kids with 22q to really kind of separate and individuate away from their parents. So I've heard of kids, sleeping in the parents' beds until about 11 years old, or being afraid of, yeah, I don't know, there's a whole family system there, but like, but that actually is something that's difficult, and it could be just the anxious tone is up, and it's hard to go through that process. So OCD has recently been connected by Dr. Duran Gothelf's group to, and the Stanford group actually, to possible risk for developing schizophrenia later. What is OCD? It doesn't look the same in 22q as it does in the general population because it tends to peak really early, like in middle school years, and then actually remit by adolescence. So it can look very different. So this is an example where this may actually be a platypus when everyone's looking at it like a duck, okay? But we define the symptoms as repetitive, intrusive thoughts. These thoughts feel alien, they feel repetitive. It's over and over again. I'm dirty, go wash your hands. In children, it can just be a sudden urge or a real anxiety. It doesn't have to have any formed thought with it. And compulsions are repetitive and time-consuming behaviors, and that's really where the compulsions are where you see it in kids with 22q, and that's spending hours organizing things, washing hands, being a germaphobe. I've seen a lot of organizing things in sort of the early spike and remission of OCD. So what happens in the general population? A third get better, much better with treatment, a third get somewhat better, and a third worsen or stay the same. And it has, if you have OCD in the general population and you get depression with it, it is a suicide risk, and so you have to really kind of watch out for that in the future. Okay, so what is OCD treatment? The best mainstay treatment for it is a combination of cognitive behavioral therapy and medications. And any treatment-resistant case, which can be a third, needs really highly specialized treatment. But any sort of psychiatrist or mental health treatment team can, open the door to that. It's not, it's not super specialized. It just means that you have to use tricky medications that need psychiatric oversight. So this is the big debate in the literature in the last year. And my favorite article that's written pretty well, easy to digest, is this kind of interchange between Dr. Elias and Dr. Borsman that was published in the American Academy of Child and Adolescent Psychiatry Journal, the Orange Journal. And they summarize it very well, arguing with each other. And it's just it's like editorial, so it's without all of the statistics and such. But basically, this is the summary right here. Interestingly, I wrote this slide with the autism expert here, Dr. Ozanoff, before even that came out. But this pretty much stays the same. Social awkwardness and language difficulty, is that autism? What is autism? Could it be early schizophrenia? Could it be severe social anxiety inhibiting normal social interaction? Could it be specific cognitive problems with a speech delay that can look like autism? We just don't know. This whole autism thing is pretty early. Now I know that having like an autism label can be helpful for services, and so that may be another reason to argue semantics, but from whether or not this label actually predicts anything in this population is just not known. Or suggest treatment, right? That's what I'm harping on. Okay, so schizophrenia. And this is about childhood symptoms of schizophrenia. Schizophrenia in kids with 22q is pretty rare. It's less than 2 to 5%, and that may be a sort of an overblown estimate based on one teeny tiny study. It may be confused with childhood bipolar disorder, but what we do know is that transient low-grade symptoms of psychosis is pretty common in kids with 22q, and that's becoming evident in my study too, which is now about halfway over. Sorry?
What are those?
I'll talk about them in just a moment. That's a good question. So it's about 50% of kids by adolescence will have transient low-grade symptoms of psychosis. And since someone asked me, I'll explain what those are. Okay. So psychosis has 4 positive symptoms, and those are the kind of symptoms that cropped up in kids with 22q that we're talking about. One of them is hallucinations, and hallucinations means perceiving something in the environment through a sense that's not there. What do I mean? Okay, so feeling, taste, seeing, smell, hearing, 5 senses, right? So just perceiving things that just without any direct stimuli in the environment. Most commonly, it's auditory hallucinations or hearing something that no one else can hear. Odd speech. I'm not talking about phonemic errors, okay? So what I'm talking about here is suddenly developing a change in syntax and sounding illogical. Okay, that's what I mean by odd speech. People stop making sense after it's kind of like a regression of speech. Odd behavior. This is some of the executive stuff on steroids. It's pretty much the planning becomes so bad that when you try to do something, it can get kind of bizarre. For example, if you're trying to dress in the morning, you can put your pants on before your underwear. Okay, that's clinically kind of significant odd behavior. And then finally, odd overvalued beliefs. The most common is feeling unsafe or feeling like there's somebody or something out to get you. Okay, these are beliefs that are not shared by your cultural subgroup. Okay, when you have 2 of these things together and it kind of persists and it causes you problems, that's when it's called psychosis. You have to have 2 of those together. Okay. When you have one of them in isolation, that could be prodromal, especially if it doesn't cause you problems. There are 3 identified prodromes, or early signs of schizophrenia in the general population. One is if you're known to have a genetic risk, which kids with 22q are, and you have a significant drop in your ability to work and play, then that could be a sign. The presence or increase in frequency of those psychotic symptoms. Okay, so if you have one symptom and it just kind of keeps becoming more frequent, that could be a sign. And then finally, if you've always had that imaginary friend that talked to you, but they seem to be becoming more intrusive in your life and making you do things, that can be a sign. Okay. For anyone who has one of these prodromes, there's a 60% chance that they'll convert to full psychosis in 2 years. And those are the 3 identified prodromes. What I'm finding out in my research is that kids with 22q will have isolated symptoms of psychosis, not meet any of these prodrome criteria. Okay, and I can't say anything about the development to schizophrenia from that. So I'll have a kid who'll just kind of hear a voice once or twice, and it'll go away. Okay, so there's no known treatment. I think family therapy was kind of alluded to earlier. There is a clinic here called the Early Detection and Preventative Treatment of Psychosis Clinic that does have family groups and psychoeducational groups. And they're looking at right now whether or not treatment helps with antipsychotic medications. So please download this. I categorized the medications for you. The stimulants and non-stimulants are for ADHD. So when you're looking for treatment for mental disorders in 22q, it's best to treat the symptoms. I'll quote Ann Bassett, and hopefully this is the take-home message of this talk, is that when approaching mental illness in 22q deletion syndrome, treat it as you do in the general population, bearing in mind the general medical problems. Okay, so that's the bottom line. There's no voodoo to this, except remember hypocalcemia, remember seizures, remember the genetic risk for schizophrenia, remember sleep apnea. Okay. So there's lots of professionals you're going to get introduced to if you haven't already in the mental health field, and it can be kind of an alphabet soup, and each specialty has their own biases and own way that they're trained. So it's best that you're exposed to kind of a little potpourri, it's best to have a mix of a couple of different specialists. Physicians have a general medical background and become psychiatrists. They train more toward the medical model and medication treatment of mental disorders. Psychologists are generally trained in assessment and evidence-based therapies. All this can vary, of course. Social workers are generally trained in case management, although some of them do go on to train in therapies. Marriage and family therapists generally train in evidence-based therapies and dynamic therapies. And you may already be familiar with all the types of speech and occupational pathologists from the early years. So I think I'll kind of stop here. I put some reasonable expectations for your clinician in mental health, and I also put up some limitations of what, unfortunately, you have to expect in today's environment. So that can be just downloaded from the website. Okay, well, thank you very much for your attention, and I'll talk to you in half an hour or so after Tony's talk.